All right, good morning. Thanks for joining us for our second installation of our pathophysiology series. Today, I'm going to be discussing gestational diabetes. So what is gestational diabetes? It is a glucose intolerance condition that's basically, obviously, by the name, is experienced by women who are pregnant. Unlike our typical presentation and pathophysiology of diabetes mellitus, this does not have a pancreatic component or cause. And fortunately for most women who experience and develop gestational diabetes, those signs and symptoms will resolve either by the end of the pregnancy or shortly after delivery. It's thought to be caused by changes in placental hormone levels during the pregnancy that end up resulting in both maternal and fetal hyperglycemia. It's essentially the placental secretion of progesterone and estrogen levels that ultimately result in a maternal sensitivity to insulin, resulting in those high blood glucose levels. Typically, this gets diagnosed right around 28 weeks of gestation and will peak as the mom goes into the third trimester of pregnancy. So what you see here, obviously, is just a summary of that. The high blood glucose levels in the mother result in extra glucose getting to the baby. And as I'll talk about, can result in rather large babies that may make delivery difficult to impossible. So let's talk about the pathophysiology. So blood glucose is known to cross the placental barrier. And so if mom is hyperglycemic, then that baby ultimately is going to have an excess glucose that does cross the placenta. And that baby now has to contend with those high blood glucose levels, just like you or I would. As high glucose levels enter the fetus will end up producing increased levels of insulin to try to normalize their own blood glucose levels. All of that extra glucose ends up being converted into fat in the fetus, such that women experiencing gestational diabetes, as I mentioned, often deliver very, very large babies, something called macrosomia. This can make delivery very difficult, if not impossible. Generally, cesarean sections are required in order to successfully deliver that newborn. So because this doesn't occur until late second and early third trimester, generally we don't see any kind of birth defects other than just having a very large baby. Women who have experienced gestational diabetes during pregnancy typically have about a 40 to 60% increased risk of developing type 2 diabetes within a decade. Infants of mothers with gestational diabetes are at higher risk for obesity and diabetes in their lifetime. So as you can see, this creates a situation where there can be lifelong consequences if this condition is not managed. So the clinical assessment of gestational diabetes, this is what physicians and nurses in the hospital setting or in a doctor's office are going to use to diagnose this. This isn't anything that we're going to be able to do in the field. Typically, our level of involvement is when we are doing our assessment on a female who's pregnant. We're going to ask certain special questions. Well, one of those should be, have you any expected complications and that kind of thing? Are you seeing any kind of prenatal care? And what that's going to do is lead us into being able to assess whether or not that particular, pregnant mother is at high risk for developing any of these associated conditions. So let's talk about what those clinical assessments consist of. So generally they do an oral glucose tolerance test. So they give mom basically a bottle full of very sugary water, and see how their body tolerates that increased glucose load. Usually this test is valuable up until about 12 weeks before delivery. Following that, typically what'll end up happening is they can do a hemoglobin A1C test, which is usually used to detect if there's any kind of a pre-existing diabetes, or are they at risk for developing any kind of pre-diabetes. So how are these patients managed? So management needs to be initiated as soon as possible. And this is going to be in conjunction with their OBGYN and their primary physician to stabilize those blood glucose levels and minimize any potential complications to both mother and baby. Management is going to include things like diet modification, exercise, and daily blood glucose testing. Generally, oral medications that we'll see in our adult patients are typically not going to be prescribed for this form of diabetes. However, they may need to have insulin injections to help normalize those glucose levels. I think it's important to mention that all of the complications of poorly managed high blood glucose levels in our diabetic patients are consistent in gestational diabetes. So you have circulatory issues, increased risk factors, heart attacks, strokes. So it's not just what all of that extra glucose will do to the growing fetus, but also the physiologic effects that it can have on the mother. And remember, during pregnancy, her cardiovascular system is already overloaded. Heart size is going to increase, kidneys are going to increase in size, and their circulating blood volume by the end of their pregnancy can increase as much as 40 to 50% their normal circulating volume. So that's, in a nutshell, what gestational diabetes is. I'm going to dive a little bit deeper into what is the exact cause of this. It is an endocrine issue, and as I mentioned, it really is an imbalance of placental hormones. So let's talk about the placenta. So just as a review, the placenta is the primary means for the endocrine system, as well as nutrition between mother and the developing fetus. As that fetus develops and grows, the growth rate of the placenta, grows along with it, and it tends to be most rapid during that first trimester. By the end of the pregnancy, full term, the placenta can weigh as much as 500 to 600 grams and can be about 2 to 3 centimeters in thickness. Additionally, it can end up being about 15 to 20 centimeters in diameter. So just trying to give you an idea of the size of this organ. And so one obvious function of the placenta is to provide the fetus with oxygen and nutrients, and to carry away any excretory products from the developing fetus. Second major role of the placenta is to serve as an endocrine gland, as I talked about, to help maintain that pregnancy. Placenta will take over the endocrine functions of the maternal ovaries and the maternal anterior pituitary. So as the pregnancy progresses, you're going to see less reliance on the hormonal levels from mom specifically, and it really is starting to shift over to being able to produce those hormones in sufficient amounts to, encourage and support development of the growing fetus. Cholesterol is an important product in making a lot of hormones that are steroid in nature. And so when we think of cholesterol, we think of, fatty foods and plaque on the arteries. And that's true, that is cholesterol, but there are other types of cholesterol that our body uses as precursors to make a lot of our steroid hormones. And if you think back a little bit into some of the anatomy and physiology topics that we discussed, the primary producer of our steroid hormones come from the adrenal cortex. And so maternal adrenal glands will support a lot of this until the placenta is of sufficient size, can kind of take over a lot of that. And it's that cholesterol that gets metabolized by the placenta and turns it into things like progesterone and estrogen. Now, those may sound like they're maternal or female hormones, and to a certain extent that's true, but both male and female will produce both progesterone and estrogen, just in different amounts. During development and support of the pregnancy, estrogen and progesterone become very important hormones for development of that growing fetus. So while this is all kind of taking place and placental production of progesterone is established, basically it's the trophoblast, which is that small kind of group of early embryonic cells that secrete something called human chorionic gonadotropin, or HCG. And HCG is what is detected as a metabolite in the urine for your at-home urine pregnancy test. So what HCG does early on is it basically helps to maintain the production of progesterone by the maternal corpus luteum, which is found in the ovaries. So let's talk about HCG, which is human chorionic gonadotropin. So in terms of HCG's importance and its role specifically in pregnancy, early on, it is in higher amounts because this is what is telling the maternal ovaries that, yes, we do have a viable pregnancy and implantation, and we need to continue to produce progesterone. So HCG production tends to max out by about the 10th week, and then will slowly start to decrease right around 17 weeks of pregnancy. The amount of HCG that's produced by the placenta in this case is minimal because now the placenta is able to produce its own progesterone and estrogen, which prior was really the responsibility of the ovaries. The major biological function of HCG is the function as what's called a luteotropin, which is just a hormone that stimulates the production of progesterone by the corpus luteum, which is found within the ovaries. And I've got a picture here that I'll show you in just a minute. So that production of progesterone ensures, the production of HCG ensures that there's a continual supply of ovarian progesterone until that placenta is developed to the point where it can generate basically enough progesterone to take over. Once that happens, there really is no need for the corpus luteum, and it's basically going to shrink in size or atrophy and eventually be reabsorbed by the maternal ovaries. So here is that diagram of the female ovary. And what you see basically is you have a bunch of follicles within the ovary. And in previous lectures, I've talked about the amount of eggs, if you will, that the female has is pretty much set at birth. Each ovary typically can contain about 200,000 of these kind of immature eggs. And then during the menstrual cycle, once a month, at random, depending on which ovary is kind of chosen, one of these eggs will be matured. And this is by increasing levels of estrogen, which ultimately leads to ovulation and release of that egg. Once that egg is released, this follicle will close up and it becomes what's called the corpus luteum. And as long as HCG is detected by this group of cells within the ovary, then the corpus luteum will maintain and will produce progesterone. Right around 6, 7, 8 weeks, when levels of placental progesterone are sufficient, then you'll see the corpus luteum basically shrink in size and get reabsorbed by the ovaries themselves. So that's just kind of an anatomy structure of the maternal ovaries and the role of the corpus luteum. All right, so let's look at a little bit regarding steroid hormones. So there's a changing pattern of production of steroid hormones throughout all of the trimesters of pregnancy, so that the fetus is able to differentiate its cells and develop. The fetal adrenals and the liver have an increasing responsibility for those steroid metabolism and production. So as that fetus develops and the reliance on maternal cholesterol and steroids decrease, the growing fetus is able to basically supply its own steroid hormones, which are precursors for things like progesterone and estrogen that we talked about, that just kind of help to maintain this pregnancy. Immediately following conception, through about 12 to 13 weeks of pregnancy, the principal source of progesterone and estrogen is from that corpus luteum. As I said, as the placenta is able to start producing those in high enough quantities, then the corpus luteum will atrophy and be reabsorbed, and that role will be taken over by the placenta. So by week 7, the placenta is producing enough quantities of estrogen and progesterone that this process can start to take place. Both placental and corpus luteum production of progesterone is stimulated by human chorionic gonadotropin, or HCG. All right, so let's kind of look at what we talked about. So diabetes, or gestational diabetes, is due to changes in placental levels of progesterone and estrogen. They're not really sure why this occurs, but for whatever reason, it results in a maternal insensitivity to insulin and glucose, which results in hyperglycemia. And it's that hyperglycemia that can cause all of these issues. Because blood glucose does cross the placental barrier, if mom is hyperglycemic, so will that growing fetus. As that fetus produces more insulin to try to normalize their glucose levels, that glucose is converted into fat in the fetus. And this can cause a very large fetal size, often having 12 to 14 pound babies at delivery. Because of this size, they tend to be a little bit too large to successfully pass through the birth canal. And so if you know that your pregnant patient does suffer from gestational diabetes, you may not want to wait on scene and try to deliver this baby. That's most likely going to be done through cesarean section, a cesarean section. And mom should know about this. Now, we should be taking blood glucose levels on mom and the newborn once it's delivered. If mom is hyperglycemic and it's been poorly managed or undiagnosed, then there's a good chance that in late stages of pregnancy that her baby is going to be very, very large and most likely is going to need a cesarean section. So you're going to want to be able to transport to a facility that does have labor and delivery as well as a NICU. For most women who develop gestational diabetes during pregnancy, it usually will resolve following delivery of that newborn. So I told you it was going to be fairly short. I'm looking to see what kind of questions we have. So I have one question that says, can a woman with diabetes 1 or 2 who goes into DKA cause an increased fetal size as well? Absolutely, right? And really the causative of this, or the causation of this in terms of gestational diabetes, these are diabetes that are that basically is a result of the pregnancy, can result in larger fetal size. Now, if that patient has a history of diabetes, then absolutely the same thing can happen, because that baby really needs to contend with those high levels of blood glucose. So hopefully that makes sense. If anybody else has any questions, feel free to put it into chat. All right, I have another question. All right, perfect. All right, well, as I mentioned, it was going to be a fairly short lecture today. Next week, we'll be continuing our kind of pregnancy-related issues. So make sure that you come back and attend that one. Otherwise, this will be uploaded to YouTube shortly, and I appreciate everybody's time.